I am Dr. Rita Suhuyini Salifu, the Principal Investigator for the Amyloidosis Project, UTAS, and we are very happy to have everybody on. We are going to be sharing some great insights into the condition, and so it's great to have you. Before we start, I would like to invite our Dean, Professor Awuku, the Dean of the School of Medicine, University of Health and Allied Sciences, to just give us a few words, and then we go on to our panelists. Prof.
Great. So thank you very much, Dr. Salifu. I think it's a wonderful opportunity for us all to interact. And as you said, this is a collaboration, University of Technology and Applied Sciences, as in UTAS and UHAS. I think we have so much in common, I guess. We're looking at rare diseases clinical awareness webinar. And the main theme is from suspicion to certainty, recognizing, diagnosing, and managing TTR amyloidosis in clinical practice. I want to say good evening to all of you, the speakers, colleagues, participants, for joining this webinar. For me, it's a great pleasure to welcome you all to this important webinar on amyloidosis. On behalf of the organizing committee, I extend our sincere appreciation to everyone for joining on this webinar. Amyloidosis certainly remains a complex and often under-recognized disorder with significant clinical implications across multiple organ systems. Advances in diagnostics, imaging, pathology, genetics, targeted therapy have transformed our understanding and management of this disease in recent years. However, the awareness is on the low side. So today's webinar actually provides that excellent platform for knowledge sharing, professional collaboration, and critical discussion on current concepts and evolving approaches in the diagnosis and treatment of amyloidosis. We are privileged to have highly experienced speakers and experts who will guide us through this process. We are privileged to have Dr. Anthony Hammer. We also have Dr. Sylvester Don Dasa, and then we have Dr. Andrew Dzebu to do justice to this. I would ask that we all pay serious attention, take appropriate notes, and after this workshop, I can assure you that your index of suspicion for amyloidosis will be high, and that will be able to make a lot of diagnosis going forward. Thank you very much, and over to you, Dr. Salifu, to moderate the session. Thank you.
Thank you, Prof. Appreciate all the support you've given us in organizing this program. So we will start off with the first presentation, and this will be by Dr. Andrew Dzebu. He is a cardiologist and also a lecturer at UHAS, a cardiologist at Hull Teaching Hospital, and who has done quite some work and seen quite a large number of patients with this condition. And we are happy to have him give us a broad overview of TTR amyloidosis. And so, Doc, over to you.
Okay, thank you very much for accepting our invitation to this webinar. My name is Andrew Dzebu. As I was introduced, I'm a cardiologist at Hull Teaching Hospital. So I will take the overview, pathophysiology, clinical presentation, and red flags for transthyretin amyloidosis. So amyloidosis is a heterogeneous disease characterized by the extracellular deposition of insoluble protein aggregates into various proteins. In theory, any protein that can misfold can cause amyloidosis, but so far we have identified 13 types of amyloid fibrils so far. Now, the most clinically relevant ones include transthyretin amyloidosis, light chain amyloidosis, and serum amyloid A amyloidosis. When we were all being trained as doctors in medical school and stuff, we were taught that amyloidosis is rare, but the fact is that it is underdiagnosed. So as Prof. Awuku mentioned, the technology has changed, awareness is changing, and so now we are able to identify patients with amyloidosis and confirm it, and also there's treatment. And before we continue, I want us to look at the nomenclature that we'll be seeing. So you see a lot of ATTR. ATTR means transthyretin amyloidosis. TTR is transthyretin. AL represents light chain, and then double A represents amyloid A amyloidosis. All right, I would also like us to review our basic sciences from medical school. I'm sure that we all looked at this in our first semester, cellular molecular biology. We know that the functions of cells are controlled by proteins. At first, there was a missing link between how genetic information is changed into proteins, but this was clarified in 1957 to 58 by Watson and Crick. This is the reason why they got a Nobel Prize. So this is what they explained to us, that genetic information in the form of DNA in eukaryotic cells first have to be transcribed into RNA, and then RNA is transcribed into amino acids. The amino acids, as we know, are polypeptide chains. But after the translation, these amino acids have to undergo, transformational changes so that they can get a three-dimensional structure which is stable and functional for them to be able to do the work that they're designed to do. Functional proteins can become unstable sometimes, and then when this happens, they misfold. That is, they adopt forms that are not appropriate for their structure and function. And these proteins become insoluble. These insoluble proteins, which we call amyloid fibrils, can be deposited in different kinds of tissue. Usually the deposition is extracellular. But when they deposit in tissue, what they can do is that they distort the architecture, the histological architecture of the tissue, and therefore they distort the function which the tissue is supposed to perform. Sometimes these amyloid fibrils are toxic. They lead to cell death and apoptosis of the tissue, of the cells in the tissue that they are deposited in. And then it causes fibrosis. Now let's look at the physiology of transthyretin. What is transthyretin? It's a tetrameric protein which contains a monomers of 127 units. Tetramer means that it has 4 parts. So each of the 4 parts has 120 units polypeptide. This is synthesized mostly in the liver. It can also be synthesized in the choroid plexus, in the central nervous system, and also in the retina. The function of transthyretin is to transport T4 and then retinol. The name transthyretin is a combination of transporter of thyroxine and retinol. So I've highlighted how the word transthyretin came to being. So trans from transporter, TY from thyroxine, and then retin from retinol. The gene for the synthesis of transthyretin is on chromosome number 18. Pathophysiology. So as we said, it's a tetramer. So when this protein misfolds, then it becomes dysfunctional. Now we have generally 2 types of transthyretin amyloidosis. There's a wild type, and then there's a hereditary type. The wild type normally occurs in elderly people. About a quarter of people over 80 years have transthyretin amyloidosis. Why this happens exactly, we do not know. Why a person is born without a genetic mutation, but when they grow, the protein that they synthesize somehow becomes unstable and then starts to misfold in the human tissue. So the reason why it happens exactly, we do not know, but we hope that in the next few years, research will clarify this issue. And then the other type is the hereditary amyloidosis. So far, over 120 mutations have been identified, but the most prevalent ones are the 3 that are listed over here. In our context, we have the V122I mutation, which is common in people of African origin, and then people who are descendants of Africans in the diaspora, for example, in the Americas, the Caribbean, and in Europe. There are also other mutations that are in elsewhere, for example, in Europe, which is the V30M, and then also the T60A, which is specific for people from Ireland. So generally, these misfolded proteins are deposited in any organ, but predominantly it happens in the heart and in the peripheral nervous system. So this is a landmark study that was done by Jacobson and his collaborators. They studied the V122I mutation in Africa, and if you can see the screen, it is very prevalent in West Africa. So a country like Ghana has about 5%, 4 to 5% prevalence. So when you do The math, when you multiply 5% by 30 million people in Ghana, you can imagine how many people have the mutation. Now, as we know from our genetics, a person can have a mutation. So amyloidosis, genetic amyloidosis, hereditary amyloidosis is autosomic dominant. It means that a person in any generation can inherit the gene, male and female. But we also know that not everybody who has the gene will express the disease. So let's do the math. 5% of 30 million Ghanaians, I think that's about 1.5 million people. Let's say that all of them don't express the gene, but a minimum of 1/3 express the gene. That's about 500,000 people. If it's the entire 5%, that's 1.5 million people. Okay, to the clinical presentation, I'm going to speak briefly about the AL and then ATTR. As you can see, both of them, especially in the ATTR, the most prevalent organ for deposition is the heart. So we have a cardiomegaly, cardiomyopathy. These patients normally present with heart failure with preserved ejection fraction. They can also have orthostatic hypotension, peripheral neuropathy, carpal tunnel syndrome, lumbar spinal stenosis, intestinal problems such as diarrhea, and then spontaneous biceps rupture. The other common one, the AL amyloidosis, the kidney is more affected. So you see these patients have renal dysfunction with severe proteinuria. And coming back to the ATTR, they might also have very minimal renal impairment. So that's a small difference between the two of them. And then also in the AL, they usually have macroglossia, and it's very noticeable on clinical exams. With respect to the diagnosis, like we mentioned, the typical symptom is heart failure. And then also you have a group of patients who have severe aortic stenosis. Aortic stenosis is usually a disease that you see in elderly people. So now you have two diseases that you can see in elderly people. Aortic stenosis, that is the calcific aortic stenosis, and then the ATTR cardiac amyloidosis. But then we know from practice that about 15% of the people who present with aortic stenosis who go for surgery, when they do a biopsy of the excised aortic valve, we see that it's actually cardiac amyloidosis. The amyloid fibrils deposit on the aortic valve and causes stenosis. And especially those who have the genetic variant of cardiac amyloidosis, they have a family history of heart failure. Unfortunately, our health system has not been very developed for a long time, so these people who diagnosed right now will not be able to recollect if their parents or their grandparents were ever diagnosed of heart failure, because as at that time, we didn't have systems to be able to make a very accurate diagnosis. Okay. Other patients may also present with a conduction system disorders such as AV blocks and also AV atrial fibrillation. As we mentioned, the amyloid deposition can be systemic, and therefore you can find symptoms from other organs that are affected, like in the hands, carpal tunnel syndrome, lumbar spinal stenosis, and the rupture of the biceps spontaneously. And then when we do laboratory investigations for these patients, we will see that they consistently and persistently have low levels of troponin elevation. The troponins are elevated does not mean that they have infarction. It just means that they have myocardial injury. And then they have very significant elevated natriuretic peptides like the proBNP that we use. And then a very important cue that we used in the diagnosis of amyloidosis is the ECG. That is one of the most common tools that we have in our setting. So on the ECG, what we are going to see is that we are going to see our QRS complexes have very low voltage as compared to the level of thickness that they have on cardiac imaging. So we know that we can diagnose hypertrophy on ECG. But if you have a patient and you send for cardiac imaging and you see that the patient has hypertrophy, but when you look on the ECG, they have low voltages. This is one of the red flags that the clinician has to keep in mind. Other findings that clinicians should pay attention to is rhythm disorders such as atrial fibrillation and flutter, especially when they have normal ventricular response. They could also see AV blocks, especially the first grade AV blocks, and then the pseudo-infarct pattern. So at the end of the tail end of this presentation, I'll show what the pseudo-infarct pattern is. And now moving on to cardiac imaging, the commonest modality we have in our setting is the echocardiogram. So this also shows a lot of red flags that the clinician should pay attention to. So you see increased LV and RV thickness. So normally in our practice, we focus a lot on the left ventricle. So for a man, the left ventricle thickness measures up to 10 millimeters, and for a woman up to 9 millimeters. So anything greater than that, we consider it LV thickness, increased LV thickness. However, LV thickness in amyloidosis can quite be severe in many cases, especially because we fail to diagnose them in the beginning. So normally we would want to say that we have been taught to say that a person with hypertrophy would have had something like hypertension. But that is one of the reasons why we usually miss the patients with amyloidosis, because we want to ascribe every wall thickness to hypertension. So when you have a patient who is hypertensive, you need to take a history to see how long the patient has had hypertension, to see if the hypertension has been well controlled or not. And then you compare it to the level of wall thickness that you see. And so this will guide you to say whether or not, for example, the hypertension could explain the level of wall thickness that you see. But then you see that we are talking about increased LV and RV wall thickness. Usually hypertension does not cause RV wall thickness. So when you see biventricular hypertrophy, then you should think about something systemic like amyloidosis. And then something that also draws your attention easily is a pericardial effusion on echocardiography, and then biatrial enlargement. Normally, in the beginning of amyloidosis, cardiac amyloidosis, you would see preserved ejection fraction, but progressively the ejection fraction starts to drop at the very tail end of the disease. And then you also see other parameters that are suggestive of diastolic dysfunction, such as the reduced E prime ratios, restrictive transdoppler filling pattern. So that will help you to guide whether the patient has grade 1, grade 2, or grade 3 diastolic dysfunction, and also reduced TAPSE in advanced cases. Other modalities in advanced echocardiography, such as strain imaging, you will see that there's loss of strain in the basal and midsections of the ventricles with sparing at the apex. I'm going to show pictures of that at the end of the presentation. So here is an example of an ECG of a patient with amyloidosis. So you can appreciate the low voltages in all the leads, especially in the limb leads. And then you can also notice that there's what we call the pseudo-infarct pattern in the inferior leads and some of the precordial leads. So the pseudo-infarct pattern is the QS pattern. The QS pattern is interpreted the same way as a Q wave is interpreted. So in coronary syndromes, we are taught to understand that the Q wave means that there's been an infarct. But here you can see there's a QS pattern in the inferior leads and the anterior leads. And it's not very likely that one person has had an infarction in these two leads. Okay, so this is what we call the pseudo-infarct pattern. So a person who on the ECG shows that he has apparently suffered an infarct, but in reality has not suffered an infarct. Here we have a parasternal long axis view of a patient with heart failure. We can appreciate the increased wall thickness of the ventricles. We can also see minimal pericardial effusion, and then thickening of the aortic and mitral valves. This level of hypertrophy is not explainable by hypertension. And then this level of hypertrophy is discordant to this voltage criteria on the QRS voltages here. So this person does not have hypertrophy on the ECG. However, he has hypertrophy on imaging. So this discordance is one of the red flags that the clinician should look for. Okay, and this is another video seen it from apical four-chamber view, where we can appreciate the ventricles at the top and then the atria at the bottom. You can notice the increased size of the atria. Normally, the ventricles should be larger than the atria, but here you are seeing the opposite. So this is a classic morphological feature of what we call a restrictive cardiomyopathy. And amyloidosis is a classical example of what a restrictive cardiomyopathy is. where the atria can become larger than the ventricles. It means that there's a diastolic dysfunction. And here is an image of what we call speckle tracking imaging. So the images that we see on 2D echo, you see that the images are conformed by dots, small dots that make up the image that we see. Now, what speckle tracking does is that it tracks the movement of these dots with time, and then is able to generate this picture. A normal ventricle will be colored red, like what you can see in the center with -22. This is the apex of the ventricle. This is normal. So it remains red while the rest of the ventricle loses its strain imaging. So where the AV valves is, here is where the base of the ventricle is, and then here is where the apex of the ventricle is. And so where the number 22 is the apex, and then where you see the 5, 3, 3, 1, -4, -8 are the bases. So amyloid fibrils tend to deposit more in the apex and the midsections of the ventricles than at the apex. So an image like this, where the color red is preserved at the apex, is what we call the cherry on top pattern of strain imaging. And then generally, the ventricle loses its global longitudinal strain. So you see a number that is -9.9. A healthy ventricle normally has -20 or above. And here we have an image from a single photon emission CT, or what we call a SPECT, or cardiac scintigraphy. So this technology was previously used and currently used to study bone diseases. So somebody at some point noticed that a few patients with cardiac diseases also show that their heart you're able to visualize their heart on this SPECT imaging. And it turns out that patients with cardiac amyloidosis are the ones whose hearts is able to be pictured on the SPECT imaging. And currently, this SPECT is one of the ways that we use to confirm amyloidosis. So in 2016, researchers led by Gilmore and his colleagues demonstrated that using SPECT imaging in patients who had previously been confirmed to have cardiac amyloidosis using biopsy, SPECT showed 99% sensitivity and then 86% specificity for ATTR cardiac amyloidosis. The specificity is a bit less because it also picked up people who have AL cardiac amyloidosis. So for you to be able to use this technology to confirm cardiac amyloidosis, you need to rule out gammopathies, such as people who have myeloma, multiple myeloma, and other inflammatory diseases. So you need to do serum free light chain assays and then serum or urine electrophoresis to be able to rule out abnormal proteins. So in the absence of those abnormal proteins, a positive SPECT is a confirmatory test for cardiac amyloidosis. Now, in case there's more doubt, that you can proceed to do endomyocardial biopsy, but unfortunately, we don't have that in our country. So this is what we'll be stuck with for now. Thank you.
Thank you very much, Doc. Just before we continue, so if you have any questions, I see some have started putting up questions. There's a button there, Q&A. You can just type your questions there. We'll try and have all the presentations, and then we can go on to answer your questions. So I'm happy to share our next presenter with you. He is in the person of Dr. Sylvester Dasa, a senior lecturer with the Department of Biochemistry and Forensic School, Chemical and Biochemical Sciences, University of Technology and Applied Sciences. And he's going to be speaking to us on how each test, differentiating AL and TTR amyloidosis, how each test informs the next step in the diagnostic chain. So over to you, Dr. Dasa.
Thank you very much. I think our earlier presenter have done justice to the topic, so it will make my work easier, and then also probably just to skip some of the things. So I think he has already taken us through the classification, and then what to look out for. Before you can think of any diagnosis, as we know, your clinical suspicion is what leads the way. So it's one of the key things. So you can see many cases without thinking this way. So, and it's good that we're having this platform to discuss this, so that some of the things that we have been overlooking, when we start seeing them, then you may be thinking about amyloidosis. And then, so if you are thinking about it, what is it in our system that can help us to probably pinpoint or say that indeed that is it, or it will slide. Okay. So the types that he discussed, the subtypes that he has discussed, are all very important, but then they have different etiologies, and that is one of the things that you will want to think about at the very early stage. We know that the AL amyloidosis is caused by some light chain accumulation, and then also that of the TTR is caused by some genetic or also old age. So if you have this, your clinical suspicion, then that forms the basis of we thinking about the diagnosis. Of course, he has taken us through some ruling out, some diagnosis and things. So this is just to add a little to some of the things that you can use to enhance the diagnosis that you will be making. So we know that normally when the body is exposed to any antigen, or let's say any foreign substance, the body makes some antibodies in response to that exposure, in most cases, if the substance is immunogenic. So it's a normal process that antibodies will be produced. And in the process of producing the antibodies, we have this light chain and heavy chain, which I will show you in the next slide for those of you probably that are yet to have a feel of what antibodies look like. All right. So we are saying that in AL amyloidosis, you have accumulation of these light chains. It means excess of it is produced. And of course, it's also normal that in the production of these antibodies, you may have some of these light chains that are produced, but there is a normal way that the body try to get rid of this light chain, and most of it sometimes filter through the kidney and then so forth. And we know that these antibodies are also initiated. They are proteins. So they are also produced by some genetic information, some genetic codes that inform their production. So there can also be some misfolding of these proteins or these light chains, and then that accumulation in the organs in some areas can cause this. And that of the ATTR, which is caused by, so the protein that causes the ATTR is a transporter protein. I think it was also explained to us in the earlier presentation. But then there could be some misfolding of it from the in its preparation. Okay, so that will lead to it's not able to perform that normal function. So usually that protein is in a tetramer. Again, in the next slide, I will show how that leads to that results into the TTR. Okay, so I hope you can see the laser cursor here. So just this is an antibody. So usually an antibody is in the form of a Y shape. So, and it usually have two chains. So this chain that I'm pointing to is usually referred to as a heavy chain. And then these side ones are referred to as a light chain. So we are saying that in the case of AL, it's as a result of some of these light chains that are accumulated in the the blood, or let's say in the tissue area that is causing that. So normally you see that in the normal production of the antibodies, you have your antibody specificities and whatever, and probably a little bit of a light chain that is in circulation or present. But in the case where you have abnormality, you see that you have a lot more of the light chains that are produced. So these excess light chains can actually accumulate, and that is what leads to the AL amyloidosis in this case. So that of the ATTR happens this way. So you have the normal protein, which is the tetramer. Okay, but then it can undergo some dissociations, and then those dissociations will lead to the splitting off into either dimers or even into monomers. So those monomers are not representing the full structure of the protein. All right, so and these monomers can aggregate or accumulate in certain tissues, and that leads to the TTR amyloidosis. And as we are told, so this could be genetics. What it means is that there is some mutations that is happening, and that is what is leading to this misfolding, or it could be also age-related. Of course, as the earlier presenter said, the age-related, we don't know what is influencing that age-related misfolding or activity or accumulation. But there could be so many reasons that can explain that to us in the future, because throughout there's a lot of exposure, and then some mutation could be introduced at some point in time. Okay, so with this background, what are the diagnostic pathways that are available to us? And let me say, these diagnostic pathways is building on the what was shared with us just a while ago. I started by saying that for you to be thinking about these diagnostic pathways, you should have had some clinical suspicion, and probably you would have gone further to do some initial checks and then some initial testing and all those things. All right. So for you to go further to differentiate or to look at, okay, the amyloidosis that I'm looking at, is it AL, is it TTR? All right, so there are a number of things that you can do. So one of them is looking at urine and blood test. So this urine and blood test will help you to differentiate or rule out AL from the TTR. Then you could go further to confirm that. So in the urine, what would you be looking out for, either in the urine or in the blood? So for instance, you look out for the light chain, where we are saying that the AL is caused by some accumulation of light chains. So you can do what we call free light chain assay. I will explain the test principle in some subsequent slide. So you can look at that, and you'll be able to quantify the level of these light chains in either urine or in serum. And then you could also do serum or urine immunofixation or electrophoresis, where you can look at the ratio of these antibodies and then the light chains in terms of, okay, one thing I didn't also mention when I was talking about the antibody. So usually we have what we call in the heavy chain, we have what we call the lambda and then the kappa. So look at that ratio, and that ratio can also inform you whether AL is present, or you should move forward to start thinking about TTR in your diagnosis. All right. Then if you're thinking about TTR, one other thing you can do, I think the earlier presenter also mentioned that, is to look at what we call the nuclear scintigraph. Okay, where you'll be looking at some of the accumulations or deposits that might have be occasioned by these improper folded proteins in the system. We could also do genetic testing, which we know these days is one of the common tests, which is more advanced for us to do some molecular level investigation. And so when we are doing the molecular level investigation, it means you have been able to rule out your AL. And so now you are thinking about the TTR. So, but when you are thinking about TTR, then there are two things. You want to find out whether it is a mutation, which is some genetic mutation that have occurred, or it could just be the wild type that have arisen for some reason. All right. So you can do that in addition to the nuclear scintigraphy. So you do the genetic testing. But one of the definitive testing also that is very appropriate for TTR confirmation is thinking about doing a tissue biopsy. So with this tissue biopsy, you pick a tissue from the area or the site that you are suspecting the accumulation is. You pick a tissue, then you can do some biopsy analysis. It could be stain, there could be several other typing that you can do. And that will be a definitive confirmation of your testing procedure. So gradually you start from some point to rule out EL, and then you move forward to that end. So I will move to talk briefly about how some of these diagnostics are done or can be conducted to help us arrive at our decision when we are thinking about diagnosing amyloidosis. All right. I mentioned that you can do serum free light chains. So in this, there are immunoglobulin fragments. So with these immunoglobulin fragments, you can use some targeted antibodies that are designed to be able to pick up these immunoglobulin fragments. So when you do that, for instance, you this is a kind of like a sandwich ELISA or immunoassay that you are doing. So we already have an antibody that can pick up that immunoglobulin fragment, the free light chains. So once you are able to capture that in your serum, then you can use a detection antibody to be able to detect them, and then you can quantify the levels. And the range varies from laboratory to laboratory depending on the test that you are using. But roughly, usually between 2 to 0.6 to 0.65 will be considered normal. Anything out of that, you start thinking about other things. All right. Then we also have the serum or urine immunofixation. As I mentioned earlier on, you are looking at detecting abnormalities in these the antibody production lines and picking up some of the fragments that they are leaving behind. So you can use some monoclonal antibodies, and then where you can do some fixing, immunostaining, and then at the end you can run some electrophoresis, which will be able to separate your fragments of interest. And of course, you always need to have what we call a ladder or a control. So this one is a ladder or a control that can guide you to be able to identify the normal proteins from the misfolded proteins. And that will also be very useful in your diagnostic pipeline. Again, I think we we were taking through this just a while ago, but just to re-emphasize that when you are thinking about the diagnosis, one of the ways is also to think about trying to trace where some of these organ depositions, or let's say tissues, could be. And so you can use some radioactive tracers to be able to evaluate the organ functions, or it can help you to pick out where these abnormalities or abnormal proteins are accumulated. So this is not specific. This was just an example I picked just to illustrate what could be happening and how you can trace some of these using radioactive tracers in the nuclear scintigraphy. All right. So another thing is to now look at the genetic level. So if we are saying that TTR can arise as a result of genetic mutation, then you could also look at the gene sequence, and then you can also look at the nucleotide changes that are occurring in the gene. And so you will also be able to pick up the abnormal gene, or let's say the mutated gene, and that will also serve as some form of confirmation to your suspicion that you had earlier on. And of course, this is one of the most precise methods these days that is coming up. And of course, it's being developed every day, so we are getting better diagnostics. The only challenge is that maybe at the level you'll be operating, whether these tools are available, which I would say is quite challenging at the moment, that we do not have these tools that are readily available in most of the facilities. You may be able to get access to these diagnostics activities, maybe in some of the research institutions. But it will be good that once this is an interesting area or something that is going to help us make clinical decisions, we start thinking about rolling it up at the level of diagnostics at the various facilities, that it can help us also help to diagnose amyloidosis. I mentioned that one of the definitive methods is using biopsy. So where you can pick some biopsy, whether you are suspecting that the amyloidosis is related to some depositions or abnormal foldings of proteins that are gathering around the kidney, around in the bone marrow, around the heart, wherever that the location is. If it is possible, and you can pick a biopsy from there, that could be the best way to go. Through mass spectrometry, you'll be able to definitively confirm your diagnosis, especially when all the biochemical testing that you have done, if they seems not to be very conclusive, this will be the best way to go. All right, let me also be quick to add that each of these diagnostic tests have limitations, as you know, for almost all diagnostics methods. They have their own limitations. So if I go back maybe to the very first one, the free light chain. Free light chains, for instance, is a very sensitive assay, but then it could also, you can have abnormally normal cases almost all the time. And why? Because the light chain can be filtered out through the kidney. So if there is also kidney problems, you have kidney issues, that kidney issue can give you false results, because it can influence the results to appear normal, but it's because most of it is filtered out the system. So it's also good to bear this in mind. And of course, combination of these diagnostic tests will be very good to confirming TTR after your suspicion. All right, so I want to thank you very much. This was a brief one just to add to the foundation that was laid for us. I will be ready and available to engage more if you have things that we can discuss. Thank you very much.
Thank you. Thank you very much, Dr. Dasa. And very interesting perspectives and things we should look out for. So we want to also share that please check your email after this webinar. We have an article that Dr. Dzebu has written to help us in our diagnosis in low resource settings. We'll be sharing that resource also with you. So it doesn't just end here. We will continue to support you to be more informed and better equipped to handle and diagnose and identify, detect this condition. Okay, so please also put your questions in the chat. We've seen a few. We'll go ahead and answer them when every speaker is done. And so we'll now go to Dr. Anthony Hammer. And Dr. Anthony Hammer is also a pharmacist and clinical trialist. He is with the Nabrongo Health Research Center, and he's been involved in lots of clinical trials, very experienced. And we are happy for him to share with us today the pharmacist role in long-term TTR amyloidosis care. So over to you, Doc.
Yes, thank you very much. And thank you to my co-panelists and the first two presenters. Basically, this is more than a residency or postgraduate program. You've done really well, and I've also learned a lot personally, but I just want to also make a contribution. Strictly managing or doing pharmacotherapy of this pathophysiological condition is not, it's a collaborative work. So it's a multidisciplinary care. So it's not limited to pharmacists alone and or physicians alone. So basically my part of the presentation, I'll be a little bit biased towards the pharmacist role, but it's going to be much more inclined also to multidisciplinary role that the team will play. So in a nutshell, this is how it's going to go. I will be brief so that we can win back some time. So let's go on. Yes, where does the pharmacist come in? The pharmacist actually adds value because it's a long-term treatment, a long-term care. This is not just malaria that you take anti-malarians and then you'll be okay within 3 days or 5 days. Or it's not just a microbial infection. You take antibiotics and you'll be good to go within 1 week. Since this is a long-term care, we need the pharmacist to play a major role, and we need the other team members to also play major roles. So we'll be seeing, or we'll look at the areas where the pharmacist will be intervening during the process of the pharmacotherapy. Pharmacotherapy is easy to do, or the goal of pharmacotherapy will be very easy for us if we know the pathophysiological pathway. And the first two speakers have really done justice to that. So when it comes to pharmacotherapy, the question we look at is from the therapy perspective is where can we intervene? At which junctions can we intervene? So when you look at it, we can either intervene at the disease to modify the disease, or the misfolding of the protein has already happened and it has affected some organs or target organs. And then in that case, we give supportive and longitudinal care. So if it is at the disease modifying stage, then we may either reduce the TTR production or we stabilize the tetramer. Okay, so it makes sense. And the pharmacotherapy is pretty straightforward. We either reduce the TTR production or we stabilize the tetramer. Now, in terms of how the medications that we use to do that, talking about the stabilizers, there are a number of medicines. They are mostly oral, like the tafamidis and acoramidis. These are not common medicines you find on the Ghanaian market, but they are available. They can be sourced for you. I will be very much interested in Dr. Dzebu's view, how he's able to manage the conditions when he diagnoses them. But The good news is that pharmacy practice in Ghana has become very global. So anytime you need any medication, you contact the pharmacy in your facility or wherever. We have platforms. They just put the advert or the request on the platform, and it can be sourced from any part of the world within a limited time period. So that gives us it's a positive news. It's a positive assurance that we are not yet at a loss. Then when it comes to the TTR lowering or the gene silencing therapies, there are these other drugs that we can use, and they are mostly parenterals. Okay, so they are available, and we can always, as I said, we can always source them for you. Now, when it comes to the pharmacist's role, because these are long-term care, as I've already said, we need the pharmacist to be able to play so many roles in terms of the medicine plan or the therapy plan, to monitor tolerability and safety, to support adherence,
So maybe Rita, we can deal with the question part whilst we wait for Dr. Hammer to bring the final part of his presentation.
Yes, Prof. So thank you. Dr. Dzebu, please, can you respond? I know you typed it in the chat, but maybe speak to the question. Yeah.
Thank you very much for the question. If I understand it very well, so the discordance means that the ECG shows low voltage and the image is showing hypertrophy. Now, let's try to marry the two together. So like I said, this is a red flag because the voltage on the ECG is generated by the cardiomyocytes. So if there's more cardiomyocytes, it means that there'll be more voltage. But if you're seeing a heart that looks thick, but on the ECG, there's little voltage, low voltage, it means that what you are seeing on the imaging is not cardiac tissues, not cardiomyocytes, it's something else. So in this case, it is infiltration by something that is extracardiac, that's the amyloid fibrils. So although the heart looks thick, it is not a cardiac muscle that is innate entirely. It's other things apart from cardiac muscles. And then amyloid fibrils are electrically inert. They don't have an electrical charge. So that is why they don't reflect on the ECG as hypertrophy. So a red flag just means that something doesn't add up, and then you have to think deeper. You have to answer the question. And ideally, it should not influence, and it cannot influence how you manage the patient. It's just alerting you that you must do a bit more of a thorough work. I hope that answers the question.
Yes, I think so. If it's not clear, please, you can always come back, Julian, for any further clarification. So welcome back, Dr. Hammer, and please, you can go ahead.
Okay, thank you. Sorry for the technical hiccup there. So basically, this is what I say, and then the pharmacist. So it's a multidisciplinary team. So for the pharmacist particularly, when it comes to care, these are some of the areas that the pharmacist can intervene in. It educates the patient about the treatment plan and the expectations. It supports adherence. So the pharmacist clinical outcome, or the pharmacological outcome of the, as to achieving outcome of the study, and so on and so forth as well. This is also just another conditions will not aggravate the adverse effect apply in the medicines and so on and so forth. So the root of that the myopathy has started disease-modifying therapy. But he also uses diuretics and antihypertensives, reports fatigue and dizziness, and has missed 2 refill appointments. And his doctor says he's unsure what the medicine does. and worries about side effects and cost. So this just goes to buttress what I was saying earlier on. So the pharmacist's response basically in a case like that will be to clarify the understanding of the disease, as re-explain to the patient what the treatment purpose or the treatment plan is all about. The pharmacist will help to identify barriers and bring solution to those barriers. And then the pharmacist will review the medications for polypharmacy issues so that if as much as possible symptoms can be minimized or adverse effects can be minimized, then that will be good news for everybody. So basically this is the role. But in a nutshell, as I've promised that I'll save time, these are the key take-home messages when it comes to therapy. So just like Dr. Dzebu started, we started with the biology, the pathophysiology pathway. You need to know exactly what you are doing, and when you're doing that, when you have diagnosed, at what stage of the disease you're talking about, and then what is the appropriate interventions you have to introduce. You work as a team, as I've emphasized over the period, and counseling also matters, but escalate when needed is very important. Sometimes, we may be in our little corner thinking we can handle the patient optimally, but the best practice will be that we need to form a multidisciplinary team and source or invite the inputs of every team member to the ultimate benefit of the patient. Thank you very much.
Thank you, Doc. Yeah, sorry about the challenges, but part of what we face here. Thank you for this. I think there's another question. Let me read. That's Ebenezer, thank you for your question. And Ebenezer says, with regards to hereditary ATTR, at what age do patients usually present? And is sex type a risk factor? Into brackets, male or female? So any panelists can respond to that. With regards to the hereditary ATTR, at what age do patients usually present? And is sex type a risk factor? Whether you are male or female, is it a risk factor? Thank you.
May I?
Yes, please go ahead, Doc.
Okay, so it's a two-part question. First, on age of presentation, and secondary, the sex. So on the age of presentation, genetic diseases normally present earlier than acquired diseases. So in the case of ATTR, hereditary ATTR normally presents at an earlier age, somewhere around 40 years, when compared to the wild type, which usually occurs after 60 years. Okay. But then also, as we learn, there are different kinds of mutations. So each mutation behaves a bit different from the other one. So, for example, in our African context, where we have the V122I, it normally presents around 60 years, but you see that the European variants will present earlier, around 40 years. So, although both of them are hereditary amyloidosis, they behave slightly differently. So that's the first part of the answer. And the second part about hereditary amyloidosis, whether it's sex dependent. So we said that it was an autosomic dominant mutation. Autosomic dominant means that both men and women are affected equally. Okay, so the hereditary aspect doesn't really distinguish between sexes, but then the wild type is usually more common in men than in women. Thank you.
Thank you, Doc. Yeah. It doesn't look like we have any other question. So let me hand over to Prof to speak a bit, give some highlights of what we discussed, and then we will wrap up.
Great. Thank you very much, Dr. Salifu. I think it's been a wonderful session. And first of all, I want to congratulate the speakers so far. Just trying to summarize it, we've heard from 3 areas in terms of clinical suspicion. And like I said, for rare diseases, if you do not think about it, if you do not have the index of suspicion, you cannot diagnose it. And that applies to the condition amyloidosis that we're talking about here. I think the first speaker actually tried to make it very practical so that in our daily practice, we'll be able to look out for it. The key thing around the ATTR version of the amyloidosis, he talked about neurologic and cardiac manifestation. Under the neurologic, the key thing you should not forget is autonomic manifestation and the peripheral nervous system manifestation. So patient who has orthostatic hypotension, you should think about it. He emphasized bilateral carpal tunnel syndrome as well. And we've been seeing these patients. And if you don't think about amyloidosis, you will not be able to diagnose. Of course, he gave us insight into the cardiac aspect of it. And I think the discordant part he brought in, the one who asked the question was thinking that there was a problem, but rather he's saying that if there's that discordance, then it means you need to think of possible amyloidosis. He also emphasized what we should look out for when it comes to the AL version of it. Macroglossia, kidney involvement are typically not the ATTR part of it, which I think these are the key things. But more importantly, his emphasis is that you need to have that index of suspicion. On the diagnosis aspect of it, what I would say is that after having that index of suspicion, I'm hoping that this project will go ahead to establish special laboratories for this, so that if you have samples in Ho and the lab is here, we can do it here. If it's in Navrongo, we will have a process by which we ship it there so that all these samples are processed for that. But for commercial purposes, if we don't make the case, we don't demonstrate that there are numbers, the testing is going to be quite expensive. What is interesting is that echo part of it would help. It's quite easy to do. And once people are trained on it, they will be able to pick these patients up easily. Special labs are what I'm asking for the project. For therapy, I think the pharmacists have shown us that in terms of therapy, we have global access. And like I said, I always talk about the business of healthcare and healthcare business. For the pharmacists, they are more or less involved in the business of healthcare. If you make a case that you have patients for it, they can access the medication for you. And if you look at the medication that we're talking about, all of them can be accessed once we're able to make that case. So I think that's my little summary of it. If there are no other questions, I'll just go on to give just my closing remarks, and I think we can end now. For me, I think we've had opportunity to deepen our understanding of amyloidosis, a condition that remains diagnostically challenging and frequently under-recognized, particularly within our part of the world. Today's discussion have highlighted the importance of early suspicion, multidisciplinary approach, collaboration, accurate diagnostic pathways, and the emerging therapies options that continue to improve patient outcome globally. I think for us in Ghana, this conversation is especially important as our healthcare system continues to advance in specialist care. There's a growing need to increase awareness of rare and complex diseases such as amyloidosis that we've talked about today. I wish to especially acknowledge our distinguished speakers for sharing their expertise and valuable experience. Your presentations have been both enlightening and inspiring. I also commend all participants for your active engagement, thoughtful questions, and commitment to continuous professional development. What I will ask is that as we live here, we should have that high index of suspicion, and you're going to learn that the patient that you are looking at as nephrotic syndrome is actually an AL version of your amyloidosis. That patient that you're having as heart failure with preserved ejection fraction probably could be amyloidosis. And as we think about it, we'll be able to make a big change when it comes to this show. Thank you very much for joining this, and over to Rita for any other information that needs to be given. Rita, over to you.
Thank you, Prof. On that note, a big thank you to especially Prof, who has led this collaboration, and because of his commitment, this session has come on. We want to also thank the panelists who made time to be with us. And you, the participants, we are very excited that you were able to join, and hope that even if your question wasn't asked today, you can still send it to us. We are going to share on the email also several social media handles where we post more information. So all does not end here. You will continue to have updates and more information on this condition And it's our hope that very soon this will not be a scarce thing in Ghana, but that we will be able to identify and be able to report and properly treat and support our populations who are struggling with this condition. So a big thank you to everybody, and I wish you a very good evening. Thank you.
Thank you. Bye-bye.
Thank you.
Bye.
Thank you.
Bye.
Bye.